So good afternoon again, and welcome to the LifeStories Live Digital Health event. My name is Gwyn Tudor. I'm the Chief Executive of Medi Wales, and I'll be hosting today's event. So it's my pleasure to try and pull things together and keep everything running smoothly. In the background, I've got Isabel Ford. Izzy will be manning the chat, there she is, and making sure that any questions that you put into the chat function are sorted out and relayed to the speakers at the end of their presentations. So if you have any questions, pop them in the chat, and Izzy will be monitoring and making sure that they get passed on. I'm going to just assume that a couple more minutes will help with getting everybody checked in and logged on. So I'm just going to get started for proper in a couple of minutes. But in the meantime, I'll tell you a little bit about Medi Wales as we are hosting today's event. Medi Wales is the life science network for Wales. We are a membership organisation, and we are owned and run by our members through a board of non-exec directors. Medi Wales' role is to promote our members' interests and to provide connectivity between the academic, business, clinical and government parts of the life science sector. All of you present will understand the need to provide collaboration and collaborative opportunities in life sciences. It's the lifeblood of our sector. The opportunities in early stage for research and development and industry to work together, and then further down towards the end of the supply chain, we need to work closely and collaborate with clinical partners. Increasingly, the digital sector, the digital part of our sector, has become more and more important. This is fairly obvious to most people who are in the sector, but the opportunities that digital technology presents are many, and the situation with COVID-19 has potentially progressed some of these opportunities to innovate through digital platforms, digital applications at a faster pace in some cases than may have happened without the motivation of responding to the COVID crisis. So the LifeStories Live program of events has been, this is actually our fifth event. We had a launch event, and then we've gone through the academic, the business and the clinical partners, and given each of those subsectors an opportunity to showcase their case studies of successes in responding to the COVID crisis, some really interesting and dramatic stories, real life stories of how clinicians, companies and researchers have been able to respond to the crisis, and obviously some real significant challenges that everybody has faced. So today we will be moving forward in the same vein, but we'll be hearing from some superb digital companies. Today's event is sponsored by a LiveCore, a Medi Wales member and an active innovator in our sector. Many of you will be familiar with the LiveCore already, and this is a real opportunity to be introduced to the company. But a LiveCore have also brought with them today Matt Reed, Professor of Royal College of Emergency Medicine and consultant in emergency medicine at Edinburgh Royal Infirmary. So Matt will be providing a presentation on his real-world experience of ambulatory ECG monitoring in the acute clinical setting and beyond. So that's going to be our keynote presentation to start today's event, and then we'll be moving on with presentations from Welsh companies Simil Connect, Bond Digital, and Concentric Health. who have all recently been in the news providing digital solutions that have been appropriate to addressing COVID-19. A company that may be new to a lot of you, but have been right at the heart of managing government's response to COVID, which is Simply Do Ideas, are presenting. And then we're going to finish off with Helen Northmore from the Digital Health Ecosystem Wales at the Life Sciences Hub, who will be presenting on some of the work that they've been doing in respect of digital transformation. So superb lineup. And I'm really pleased that we are able to welcome all of these great speakers. And if I'm a little bit ahead of time, but I think I'm going to hand over to Sean Warren, who's the Business Director, UK and Ireland for AliveCore. And Sean is going to give a little bit of a preamble and present and introduce Matt Reed's presentation. So Sean, if I can hand over to you.
Ooh, hello, can you hear me okay?
Yes, we can.
Thanks, Izzy, for promoting me to panelist. Good afternoon, everyone, and yeah, thanks so much for joining today, especially with Boris Johnson in the House of Commons currently at the same time. Hopefully we'll deliver some better news. So as Gwyn very kindly introduced me, I'm Sean, I'm the Business Director for AliveCore for UK and Ireland. I just wanted to say a huge thank you to MediWales for the opportunity to support this webinar. Today, we're always very keen to provide education and share best practice, especially in the most difficult of times. So thank you for the opportunity for that. At AliveCore, our mission is to save lives and transform cardiology. We do this by delivering intelligent, highly personalized heart data to healthcare professionals and patients anytime, anywhere. And we're extremely proud to be supporting the NHS and the UK for more than 5 years. And a fantastic example of that is how digital transformation can make a huge difference to patients and NHS staff, which will be presented shortly. So without further ado, I have the pleasure of introducing Dr. Matt Reed. So as Gwyn mentioned earlier, he is a very busy consultant in emergency medicine at the Edinburgh Royal Infirmary and the Professor of Royal College of Emergency Medicine. So thank you very much, and over to you, Matt.
Thank you very much, Sean and Gwyn. Can I just check you can hear me okay?
Sorry, yes, we can hear you.
I'll just check that out to start with. So I'm just going to share my screen. Great, so hopefully you should be able to see my presentation there.
Perfect, thank you, Matt.
Great. So yeah, as Sean said, so I lead Emerge, which is the largest emergency medicine research group in the UK. And I'm going to present to you some of the work we've been doing using the AliveCore device. So here are my disclosures. I'm going to talk to you about the iPED study, which was funded by a British Heart Foundation and Chest Heart Stroke Scotland grants, which included funding of the AliveCore device. And AliveCore themselves had no involvement in the study I'm about to present. So this is Mrs. M. Mrs. M was out for lunch with a friend in Edinburgh when she suddenly felt palpitation and dizziness and felt extremely unwell. By the time she arrived in our emergency department, she felt back to normal and she had a normal ECG. This had happened on a number of occasions previously, to the extent that Mrs. M had become worried about going out even to walk her dog, as she had become more aware of the lack of seating outside of her house as she did start to feel unwell again. So palpitations is very common. We see an awful lot of patients per year in the emergency department, and it's also very common to present to the general practice. And the problem is that the only way to make a diagnosis is to record an ECG at the time of symptoms to get an ECG symptom correlation, and that can be very difficult. And we have many patients who present to us. The symptoms have settled by the time they've come to the emergency department. Their 12-lead ECG is normal, and we have very little to offer them. We advise normally to return if they should get symptoms, to attend the GP for an ECG or to phone an ambulance to try and get an ECG while they're having symptoms. And the reason is that the standard care is generally a Holter, a monitor, and the diagnostic yield is very poor for picking up palpitations during the period of monitoring. So we came across the cardiomobile technology several years ago, and what it is, for those of you who haven't seen it, is a device where there are 2 electrodes, and the patient can put 2 fingers on each electrode. And if they're out and about and develop symptoms, whether in the supermarket, for example, they can just sit down, grab the device from their handbag or wallet, and they can record an ECG for 30 seconds. And the ECG is connected up to their smartphone, and the ECG is on their smartphone, so they can either take that to their general practitioner, to a hospital clinic, or they can email it to their general practitioner. And the device is also able to interpret it, and it gives you here, hopefully see that's a normal ECG for me, which is good, but it also gives you a diagnosis of atrial fibrillation, a tachycardia, or a bradycardia. So we thought this would be hugely helpful in our palpitation population, and we set out designing and conducting the iPED study, which was published last year in the Lancet eClinical Medicine. So this is a multi-center, open label, randomized control trial in 10 centers across the UK, and we enrolled adults who were presenting to the emergency department with palpitations or pre-syncope, so near blackout, and there was no obvious cause in the ED. And normally that meant that the underlying ECG and the ECG in the emergency department was normal, and their symptoms had settled, so we're unable to correlate their symptoms with an ECG. So we randomized patients to either the intervention group. They received standard care, plus they also received the AliveCod device, or a control group who received standard care alone. And our primary endpoint was detecting a symptomatic rhythm at 90 days. So just to give you an idea what standard care consisted of in our standard care arm, more than half of the patients who were in the standard care arm had a referral to some kind of medical practitioner, whether that was general practitioner, cardiology services, other outpatients such as medical services, or cardiac electrophysiology services. And the ones who were diagnosed during that time, you can see that the methods for diagnosis were Holter, and also as 12-lead ECG when they returned to their GP or the ED with symptoms. So as with all studies, we took a while to get going and getting the sites up and running, and we recruited our 243 patients over an 18-month period. You can see there's slightly more females than males, which again common to this presenting complaint, and the majority of patients presented with palpitations. And you can see in the study we had patients up to the age of 74, so that didn't really limit the age obviously being a factor and using technology. So our primary outcome in the intervention study group, we found 55% of patients we were able to diagnose the underlying cause of palpitations by picking up an ECG at the time of symptoms, and this was 5 times more than in the control group. As would it be expected with palpitations, 16 to 17% of these were cardiac arrhythmias, so atrial fibrillation, flutter, SVT, and the rest were all non-cardiac rhythms such as sinus rhythm, sinus tachycardia, ectopic beats, sinus bradycardia. And that's common to most studies that investigate palpitations. We looked at how long it took to, on average, to detect the rhythm, and in the study group, it was about a week and a half. It was about 6 weeks in the standard care arm. We also looked at the pickup rate of cardiac arrhythmias, symptomatic cardiac arrhythmias. We picked up 11 in the study group, and we picked up 1 participant in the standard care group. So because they are randomized to each group, there's obviously still 10 patients who were in our control arm who were unable to detect their underlying cardiac arrhythmia during the trial. We looked at costs, and this included the cost of device, cost of coming back to access healthcare resources and to access investigations, and the costs were 3 times higher to pick up a diagnosis in the control group versus our trial group. This is just a snapshot of the patient reported outcome measures, and you can see patients were overwhelmingly satisfied with using the device. So back to our patient, Mrs. M, she was enrolled in the study. She had another further episode some weeks later whilst at home, and her live core ECG recording showed an AV node reentrant tachycardia. And her GP referred her up to the clinic, to the cardiology clinic, and she underwent a successful ablation. And she acknowledged it absolutely changed her life by allowing her to be able to go out and not be worried about getting symptoms where she was out. So I noticed the All Wales pathway for AF, the clinical pathway, does advocate use of an event recorder and devices such as the AliveCore for patients who may well have AF which hasn't been picked up. And we're now using the AliveCore device in our hospital, and we set up the smartphone palpitation service in Lothian. And the way this works is that patients who are seen in our emergency department or in our acute medicine unit who present with palpitations but don't have an underlying cause in the ED or in our acute medicine unit, they come back the following day and they're seen in our acute medicine ambulatory service. Now, we looked at also in our study how long it took for us to detect underlying rhythms, and we found that more than 9 in 10 of the patients picked up a rhythm within the first 28 days. So what we've decided to do with our smartphone clinic is that we see the patients the next day, and we then see them 4 weeks later. And this enables us to turn over the devices a bit more usefully, and also allows us to be able to see patients shortly after they've recorded the rhythm, and they don't have to go for weeks on end then to be able to come back to be referred on. In our study, the patients emailed the ECG back to our study team. In the clinical service that we've set up, the patients come back, and the reason for that is that it means we're able to retrieve the device back off them, and also it allows us to be able to give them advice and to advise what the next steps if they do pick up a cardiac rhythm. And mostly it's referral to the cardiology service and sometimes back to their general practitioner, for example with AF, to think about anticoagulation and rate limiting medication. So the clinic's been up and running for more than a year now, and we looked at the first 3 months of the clinic to see how the clinic was performing. And during that time, we saw 68 patients being referred, of whom 54 were fitting with the device, and 50 of those came back after their period of monitoring. I should add, if patients did come back after 4 weeks and a diagnosis wasn't made, we did send them away again for a further 4 or 8 weeks with the device. Again, slightly more females than males, and we were seeing people up to the age of 80 in this clinic. About 8% of the rhythms we picked up were cardiac, and they were atrial flutter and fibrillation. But we do know over the following year, we've picked up many more episodes of SVT as well, flutter and fibrillation. So we looked at what lessons we could learn from the first 3 months to see how we could better improve the clinic. We sometimes felt that a 4-week follow-up was too long, and the clinicians within the acute medical unit did find that there were patients who recorded rhythm within a week and would phone the clinic and asking to come back to be able to get some advice and treatment. So we're keeping a default at 4 weeks, but we do allow the patient to contact the clinic if they do feel they've recorded symptomatic ECG. I'm keen we don't reduce that much longer than that, but we do know, as I say, that 9 in 10 patients were recording symptomatic rhythm within the first month. Our hospital Wi-Fi was particularly poor. We found that in the clinic, reception was very poor, and it took a while to download the app. So we've changed that now so that patients download the app before they come back to the clinic, which saves a bit of time, and they seem to be very happy to do that. The patients were coming as well with expectations from the emergency department that they would be fitted with the device, and on occasions the clinic staff felt there was an obvious cause, or that the patient didn't really warrant investigation. So we've made it clear that they'll be assessed for fitting with the device when they come to the clinic. The clinic's run by a wide variety of staff, and occasionally some of the more junior staff were not totally comfortable in interpreting the ECG, and because of that, if there wasn't a consultant around in the clinic at that time, we've made it then be able to have access to the emergency department consultants and the acute medicine consultants just to run any ECGs they want any clarity back on. But the clinic is consultant run a lot of the time, and there are lots of the decisions made obviously or at senior level, and we're trying to improve that as much as possible. The patients were sent away with diaries, but universally were very poorly completed, and we also found that during the trial. But we did find that patients would tend to only record ECGs that were made during symptoms, and we get them to sign a thing at the beginning just to say that they won't use it, they won't get other friends, relatives to use it down the pub and things. It's just for them, and they'll be the only people that will record rhythms on it. So the only other things to add was we slightly changed our referral criteria as well to make it clear that we should only be referring people to clinic in whom the treating clinician thought there was a high suspicion of a cardiac dysrhythmia. And if they felt it was likely anxiety, for example, or sinus tachycardia, sinus rhythm, then they probably weren't suitable for the clinic. And the evidence behind that was in the IPED study, we found that if the ED clinician felt the chances of the rhythm being a cardiac one was more than 5 out of 10, then they very rarely missed a cardiac dysrhythmia. So we felt that ED clinicians were able to make a reasonable assessment of those patients that didn't have a cardiac arrhythmia, and that these patients probably didn't warrant referral. They tend to be picked up at recording multiple episodes in the first couple of days, and these were probably best managed by maybe a bit more prolonged monitoring in ED, or probably a 24-hour tape which could easily pick up these rhythms within the first 24 hours. We decided we better log our devices a bit better so we could know exactly the devices coming and going out and who had what, and be able to not lose any devices. And we made sure that after 12 months we routinely changed the batteries to make sure we didn't lose any devices during when the patient had the device. So where do we go from here? So we're going to look at a year's worth of data to see if the changes we made after the first few months have improved the service. At present, only emergency department and acute medicine unit can refer to the clinic. We can't accept GP referrals at the moment. We're hoping to be able to be funded for doing that, and to integrate better with the cardiology service, which do use the device on a sporadic basis, but not as part of a clinic setting. And again, this is just really because we didn't want to be overwhelmed with patients being referred to the service until we got it established. We've collaborated with other health boards as well to help them establish services by sharing our protocols and guidelines. And this model is very generalizable to all different settings. It could be run within a GP practice, within a acute cardiology setting or clinic. It doesn't have to be within an ambulatory care setting, which is how we've done it. And obviously the service, given where we are at the moment with COVID, it does lend itself to be able to send devices out to patients. They can email ECGs back in and send devices back again, and consultation can easily be done over the phone. Cardia have also brought out a 6-lead ECG, which enables all limb leads to be recorded, which may allow better interpretation of ECGs. We're going to trial out on several patients in our clinic to see whether this does add to the pickup rate and the ease of interpreting the rhythms. But that was launched last year. So to summarise, we believe certainly in Lothian that a smartphone event recorder such as the LifeStories is safe, it's non-invasive, it's easy to use, and it really does offer something to patients who present with palpitations when previously we really didn't have anything to offer them. Thank you very much for listening. Any questions?
So Sean, would you like to add anything to that presentation, or should we see whether there's any further questions?
I think a few questions are trickling through, but I think Matt did an excellent job there. And I think it's quite staggering to understand that Matt mentioned 300,000 patients a year present to ED with this potential problem. And you can imagine from Matt's study side, from my understanding, Matt, there was only 15 sites which actually were involved with this. And there are many sites still out there across England, Ireland, Scotland, Wales, where they are still using the standard of care. And in England alone, just to give you some perspective, there's over 500,000 people who are undiagnosed with atrial fibrillation. And if you have atrial fibrillation, your risk of stroke is 5 times greater. And we know that cardiovascular disease in particular is a global killer. So this is a big concern. It's a big interest area. It's a big driver for all the countries to support this patient cohort. And we believe this is a replicable service which can easily be done and supported with our technology. So thanks so much, Matt, for obviously identifying that as well. Are there any questions from your side, Gwyn and Isabel as well? Sorry.
Yeah, I'm just having a little look at the chat. Thanks so much for that, Matt. We've got a little comment here from very much a friend of MediWales, Alan, who says he's got one of the first AliveCore monitors and it does work, which is fantastic. And I was just having a little browse online, and I have to say all the reviews are basically 5 stars, so it's fantastic. And I know I've told a few people about it actually since coming across you guys as members. So it's great to hear more about how it's how it's working in practice. So one of the questions we've got here says, were diagnoses made on LifeCore tracings, or did you have to repeat on a 12-lead ECG before formal diagnoses are made?
So yeah, so that's a good question. So so the reason that the AliveCore is so beneficial is that we just can't pick up these rhythms on a 12-lead ECG. So by the time the patient's recorded the rhythm on their device, they may be out in the community, they're not in the hospital, and by the time they come to hospital or the GP service, the rhythm has stopped. So it's really not a problem for someone who presents with an SVT. They're still in SVT. We record it in the ECG or atrial fibrillation in the emergency department or in the GP practice, because we know that's what the rhythm is. It's picking up those patients who have short-lived episodes, or quite commonly these episodes don't last for a long period of time. They may only last an hour or two, by which time the patient gets to the emergency department or to the GP practice, they're back to normal sinus rhythm. So no, that's the reason we can't pick it up on a 12-lead ECG common in these patients. But we can print out, or we can download the electronic ECG or print it out and put it in the patient's notes. And our cardiologists were more than happy to make a diagnosis based on the AliveCore. And in fact, we now do commonly see patients presenting with their own AliveCore device that they've purchased, or it's very common, like with their Apple Watch, for example, to the emergency department. And now we have to have a system for being able to download these ECGs to put into patients' notes, because that's not uncommon.
Great, thanks very much. I've got another question here. What is the cost to user or clinic?
Sean, do you want to answer that one?
Yeah, so the single lead device is £82.50, excluding VAT, and then the 6-lead device is £124.20. And to give you some more perspective from a service side, I think Matt alluded to the cost effectiveness side to this, which was actually looked at in the iPad trial. Matt, would you mind just touching on that from a holistic approach of the cost saving? Yeah,
sure. So obviously the cost of any presenting complaint or any underlying problem and making the diagnosis is made up of lots of different aspects. Patients may receive multiple investigations before diagnosis is made. So we looked at all investigations that patients had related to their palpitations over that 90 days. There may also be repeat attendances. So what we also looked at, it might have been, for example, that giving patients the AliveCore device meant that they continually became worried and continually came back to the emergency department, and we didn't actually save presentations. And that could put costs up because they were seeking more assurance, more GP practice attendances, more ED, but we didn't find that at all. We found it was very rare for someone to represent to the emergency department with the device once they'd received it. They felt they were being looked after and getting the right investigations. So we looked at the cost per making a diagnosis, and we found that in the AliveCore group it was 3 times less, and the reason for that is mainly related to investigations in the standard care arm that were fruitless, basically didn't detect the underlying rhythm. So multiple 24-hour monitors we found very frequently, which were all very unrewarding.
Thanks, Matt. We've got one more here. Who monitored the ECGs / took the rhythms, and how easy was it? Is there any training required?
So during the study, we asked patients to email their ECG tracing back to our study team, and they were interpreted. It was the emergency department consultant who was on for the day who would interpret all the ECGs. They were reasonably easy to interpret. Sometimes patients on occasions would get quite a noisy ECG, and we would ask them to repeat other ECGs or wait for another symptomatic episode. But anything that had picked up a cardiac arrhythmia was normally fairly easy to see, and the majority, I would say, certainly sort of around about 90% or more of the ECG traces we had were able to be read.
Excellent. Is that all the questions in the chat?
We've got one more. I think we've got time for one more.
Yeah, I've got a question for Matt, but I'm just waiting for.
Let's do this one quickly. How did this impact on your colleagues, and do you see this helping in the community also to reduce face-to-face consultations?
That's an interesting question. My colleagues in the emergency department, they really like it because now they have something to offer patients rather than saying, "I'm sorry, we can't find what the underlying cause was." So it was actually the acute medicine team that actually run our ambulatory clinic, and collaborating with them to set this up, I thought might be difficult because obviously it's more work for them, but they absolutely love it as well. Because they find it very rewarding that patients are coming back and they're able to give them a diagnosis when they return from their clinic on most occasions, and they find that when they do pick up rhythms and make a diagnosis and reassure patients or go on to investigate patients and refer them on, they do find it very rewarding. So yeah, generally I found it's very positive.
That's great. Thank you very much for that. So Matt, I've got one more question for you, and it's really maybe to provide a bit of guidance to some of the other companies who might be on the call. Obviously, undertaking a trial in a live acute care or emergency care environment must present quite specific challenges and quite specific problems. So would you have any advice off the top of your head to especially small companies who may be undertaking trials for the first time into how they should engage with the clinical community, and are there any specific considerations when it comes to acute or emergency care?
You're absolutely right. The environment of emergency department is very difficult to do research in, and that's why our research group is very specific to just the emergency department. So we don't do trials, and we do around the rest of the hospital. And we do find that people who are dedicated to work in the emergency department are much better at delivering emergency department studies. They can be quite a stressful place to work. There's lots of anxiety amongst patients, relatives, staffs, people who are very unwell. We're meeting patients at a very difficult time in their lives when they come to emergency department. So all of those things, those stresses do make it difficult, but it's very, very doable. And I would just urge anyone who might be thinking of doing research for the emergency department is to gauge really early on with your emergency department research team, because they will be able to give you advice about what can and what can't be done, and how things are better suited to the emergency department. To be able to deliver these things, and also to think of the emergency department as a place where research can be carried out. For example, this study, it was myself who saw the technology, and I thought, well, this is going to be great for our patients, whereas it hadn't routinely been used in the emergency department setting before, because maybe people felt that, well, it's a very difficult setting, and not really appreciating that it could play a really big role within the emergency department, appreciating there are the patients there who would benefit from it. So yes, just to consider emergency medicine, and we're a very established research community now across the UK in all 4 nations, and yes, to engage with us, to be able to work up and to be able to design these kind of studies that can be done in the emergency department.
Thank you very much for that, and presumably it's also an environment where the appropriate and successful application of technologies can have a genuine impact. So so very, very worthy activity. Thank you a lot. Thank you so much for that, Matt. It's been really interesting listening to you. I understand that you will have to go because I think you've got patients to see or colleagues to meet before the end of this event. But we will carry on monitoring the questions and we'll pass them through a live call to you if they can be answered. But I think you're here with us for a few more minutes, aren't you? Anyway, so
yeah, I can stay around for a bit, so I'll look at the questions and respond to any that I can. Thank you for having me on. Thank
you. So now we're going to move over to SimulConnect. SimulConnect have been members of MediWales for a long time. We've seen the company go right from its very beginnings to its current manifestation. And we have Savannah, who is the CEO of SimulConnect. So I'm delighted to introduce Savannah. And Savannah, it would be really interesting to know what your company has had to deal with in terms of COVID challenges for your company, and where your technology and your where your services have been applicable to in a clinical setting in relation to COVID as well. So Savannah, if you are there and we can,
yes, I am here.
Then I will hand over to you. So you're welcome.
Thank you very much indeed, Gwen. Can I share my screen?
Yep, you should be able to.
Can you see my slides?
Yeah, that's great.
Lovely. Thank you very much, Debbie, Gwen, Isabel, for all your support all these years, not only for now. And good afternoon to everybody. So what I'll do is I'll briefly talk to you about SimulStory during just these last few months and how our technology has been used to tackle a care monitoring concern during this lockdown period. So generally, chronic conditions are done face-to-face appointment at a clinic or at home, as we all know. And appointments are generally given sequentially, or the patients call in. All data capturing by the patients are done paper-based, and clinicians sometimes capture the information during the consultation time. On paper or on, if they have a system, they do it on a system. And we all know very well, and we're all aware of the risks and the concerns of the human paper-based processes we have. I'm sure people in this, working in these areas, will have more stories to tell. Every time I meet somebody, I hear a new story. But what has come up recently, not recently, during all our work with all the clinicians we have, it's about the untapped data. It's about the undiagnosed information, which we just heard from a live core, and very interesting talk about the studies. I was really interested. I am going to talk to you as well. But it's all about the at-risk assessments and highlighting that. So the consequences are obviously clinical monitoring is preferred according to the patient needs. But clinicians and patient groups stress that the sequential booking, patients are not seen preferentially, it's booked sequentially. So many a time, a patient could come and visit and said, oh, you're actually okay, and could have been avoided if the monitoring was done or known beforehand. But if it's an urgent time and the slot is not available, then the patient might end up in A&E. And also, if seen in an emergency, the updated patient records might not be available. Therefore, informed decisions might be delayed. And these are current situations which we've been talking to people and doing a lot of research work and solutions. And then came the COVID situation, which altered all our norms, all our lives, with lots of challenges. Basically, for the chronic condition monitoring, the face-to-face was possible, only the emergencies were done. COVID-related needs were more needed. The home visits had to be reduced because with the care home issues and everything else. And also the organizations had a reduced staff level because of the social distancing. They were isolating themselves. So what happened was NHS was forced for faster adoption of smart technology. And it came out in the primary care first and digital NHS, how quickly NHS was adapting to these different technology that's been coming out for a while, and how quickly they were doing it. So things like video conferencing using medical devices have come up. However, the challenge of continued monitoring is still there. And so to address this challenge, Simul designed the remote patient monitoring. And in this remote patient monitoring, we partnered with EMIS Health. And with the new approved solution, it was launched in June and now moving in scaling it up in England. So what it does is it empowers patients, it engages patients, so they respond to questionnaires from home, and it goes directly into the clinical system securely and with all the mapping of the clinical coding. And we've also created a priority alert list so the clinicians are notified of the
Hi Sabana, can I just check your connection, please? I think we're losing your audio slightly.
Oh.
We're sort of phasing in and out, I think.
How about now?
No, it was a bit louder before.
Oh. Hello?
No, we don't seem to be able to get you. Like it was sort of going in and out a little bit.
Okay, because I can hear you very well.
I've just had a message on the chat saying the audio is a bit poor. So I wonder if we could increase that at all if your headset's working.
Yeah, my headset's working. I can hear you very well. And before going in, I checked it as well.
Yeah, it worked just then, and then you cut again. So I'm not sure whether it's the cable or perhaps movement at all.
Oh, I'm trying not to move. How about now?
No.
Shall I try without the headset?
Yes. Well, that was a little bit clearer then. Have a go. No.
No, because I know. Oh, that's really. Hello.
That's better. Yes. Hopefully it won't cut out. Try like that. Perfect. I'll get back to it. Thanks, Aparna. Thanks.
Sorry about that. Okay, so here is a schematic flow diagram just to show how the data flow occurs within the clinical system and the patient. We had created this system for integrated autism monitoring in Wales, but that's yet to go alive. But redesigning this solution with the patients in the GP, in the primary care area and community care, then had a bit more success. We were a bit more successful in reaching the market, addressing the needs. So just to give you the actual screenshots, just to give an idea of how it works. So the GPs or the clinicians, practice managers, receptionists, whoever is allowed to use the system, will just search for patients within their own database, and just with a few clicks can select questionnaire from the library or the document library, which are also customized according to their needs. So the patient now gets an email or an SMS with the links, and they just click the link to open. So for the patient as a user, they can do the clinical questionnaires, and there are, all the identification and the security built in, but they can also be used for information giving or some videos like for asthma, how do you use the inhaler, or anything else that you need to give information to. Clinical responses come back to the clinical system securely to the respective patient consultation page, as well as mapping to the clinical codings. So there's no extra learning for the people who are already using the system. So no minimum learning, which is one of the things we know, delays adoption of technology. What we understood realized very soon is that because people will be getting these remote solutions many might be giving it, and for the clinicians to understand which one is a priority, they have to go through the records. But what we did was created an analytics module, which is an intelligent interactive one, which identifies each questionnaire with the scoring, and it identifies which patients need you quickly. It could be for COVID, it could be for anything else. So here, like we are showing a mental health at-risk assessment questionnaire. And with the RAG alerts, the red, amber, green alerts, the organizations can also customize according to their thresholds. So if, say, 18 is a red alert, and organization would say, I would like to know when there are 16, 17 in the score, they could change that as well. So it's flexible and customized. And with these reports, because the database already has patients' addresses, the postcodes, and stuff like that, we can easily create geolocation mapping. And these mappings are useful for not only COVID, it could be for flu, cough, or any other infection, or anything else needed, feedback, questionnaires, or whatever. But the capability is there, it's built in. So to go for the COVID situation currently for chronic condition monitoring, and the backlog, waiting list, and costs were what was the main three concerns. There are other concerns as well. And this needs to be reduced, which the patient does, the remote.
We have 2 minutes, Sabana.
Yes, I'm nearly done. At the same time, the time efficiency, wider reach, and satisfied patient is also needed, and this is the added benefit that they receive. So the reason we could do it so quickly is because of our modular framework, which we've already built in LifeStories and was used in all our R&D projects we did with the health tech challenges, SBRIs, Bev and exemplars. But for this one, it just affects. So the reporting analysis module or the integration engines or the secure data could be used for any other purposes as well. It could be for the clinicians, for the patients, for independent systems, as well as device integration. So if the devices are there, they are emailing doctors. Instead of emailing, it could go there directly and very easily. So just like to thank you very much for listening, and we are very open to collaboration. If you want a discussion or a demonstration, please feel free to connect directly or through Mediwales, who's been one of our partners for a very long time. Thank you very much.
Thank you very much, Sabana. And I'm afraid the audio was pretty terrible for some of that. So I sat there with my volume switch going up and down, and I think I grasped most of it. So I think I grasped the presentation. But I think rather than try and do the Q&A at this point, I think we'll move on to the next presentation, and then we'll try and compile the quick. Are you with us for a while, Sabana?
Yes. Yes.
Okay. So we'll.
I'm so sorry. I don't know what happened. I've used this just this morning as well for a meeting. I don't know what's happening.
It's probably gremlins in the machine. Thank you so much for your presentation, and we did have notes on screen so that we could follow along as well. So that helped. So I'm going to introduce Daph Loughran from Concentric Health as our next speaker. And Daph, I'm really hoping that you haven't got any audio issues, but Daph is speaking on transforming how and where we make the decisions about our health. And Daph, if you can just test your microphone first.
Yeah, hello, can you hear me?
That is absolutely perfect. So thank you very much for that. And we can also see your screen.
Good stuff. Thanks, Gwen, and thanks for the invite to just give what is a very short, sharp kind of presentation. Just kind of introducing Concentric to those who kind of don't know about us, and just a little bit of reflection on what the last few months have looked like for us. So, as I said, I'm just going to kind of cover a little bit about transforming how and where we make decisions about our health. Bit of background about myself. So, Dav, CEO at Concentric Health, surgeon by training. Left kind of traditional surgical training about 5 years ago, and have since done a variety of things in kind of health tech before taking on Concentric, which had been kind of a pet project and a bedroom project for a number of us for a number of years. And we were given grant funding from Innovate UK early 2019 to kind of make that a proper thing and solve the consent problem. So Concentric is a digital consent application which makes it really easy to digitally transform that current paper process around consent for treatment. So for those of you who aren't aware, globally, across all of secondary care, any consent for treatment, be that surgical operations, procedures, oncology treatments, chemotherapy, all that kind of stuff, has traditionally been a paper process based on carbon copy, blank template forms. So we are one of a small group in the UK and internationally, kind of tackling that problem. And we now have a digital application that we think kind of solves that problem and gets us a number of steps along that road. And of particular note on this slide is that remote element, and I'm going to speak to that a little bit in the next few minutes. But essentially makes it really, really easy for clinicians to share personalised evidence-based information with their patients to support that conversation and getting to informed shared decisions. So we see shared decision making as a key factor in kind of how we can help. So the reality over the last few months or so, we deployed our initial kind of deployment at Imperial in early March. And since then, we've certainly been in the group of solutions that COVID has accelerated, many-fold in terms of the requirements and the number of asks coming to us for a solution. And so, from an initial deployment at Imperial in March, we've now seen deployments in the UK, in Europe, and recently one in Australia as well. And so, there are some reasonably big names here in terms of Imperial, Chatham, Westminster, Jersey doing trust-wide deployments, so across all of their departments, be that kind of surgical, radiology, oncology, and we've also got some smaller pilots happening in Wales. So Swansea is probably the kind of biggest one, but we've also got deployments in Cardiff, in Cwm Taf, and in Velindre. So in terms of kind of the response to COVID-19, I mean, it's kind of quite interesting. I look back at some of our kind of team-wide comms back in February or so, and there was that kind of initial couple of days where we were like, well, we can see that surgical activity and elective care will be hit by this, and we kind of weren't sure what our role was in helping that for that kind of first 24, 48 hours that we were kind of thinking about it. But it became quite apparent that there was a lot of activity that needed to continue in terms of cancer care and kind of very urgent and emergency surgical work, oncology work that absolutely needed to continue during wave one. And then there were a number of organizations that were quite quick in terms of thinking about their recovery and what we've seen over the last couple of months, before we enter another phase from kind of this week onwards. But we realized, and or certainly we had a sense that remote consent was an area that we could really support, and that was backed up by a number of conversations, one after another in kind of quick succession early in wave one, where there was transformation work that was being done in terms of remote consultations, and then the following week we would get contacts from those clinicians kind of saying, oh well, I've just changed my consent consultation that I have with patients a week before surgery to being remote, but now I can't do that kind of consent element of that consultation. And I don't want to fall back to consenting on the morning of surgery and all the sort of issues with that in terms of legal side, but also patient experience and supporting decision making and shared decision making. So we were quite fortunate to be supported by a Welsh Government grant, which enabled us essentially to say, right, that's our priority for the next few months, and really deliver that. And what that meant actually was, we did that at Imperial initially, but very quickly others kind of said, oh, we also need that. We're seeing the challenge in terms of consent processes. And from my perspective, what that has meant is that many of these deployments have been able to say, yeah, great, let's not bring patients in for these kind of risky physical appointments pre-treatment that we would otherwise have had to fall back to, or switch to day of surgery consent. And the impact of that, so some of that is kind of obvious impacts in terms of switching to a digital platform meant that the vast majority now have digital access and easy digital access to their own personalized information. And interestingly, if you look at our kind of data, just under half of all the consent episodes that are happening globally at the moment are remote consent. So it's been a functionality that's absolutely made its way into the usual way of using this application. But I think one of the kind of interesting reflections for me is some of the kind of unexpected consequences and benefits of some of the move to being kind of remote and digital, and reducing the kind of in-person exposure. So we've seen quite a number of people saying, that they weren't wanting to have lengthy conversations in person with patients because of obvious reasons, and often that was those were kind of lengthy conversations on the morning of surgery. And so they were making a decision, well, let's kind of share some of this information, or do a quick phone call or a video call a few days before surgery or a week before, or kind of shift to a consent consultation remote model. And the incentive for that was that they didn't want to be spending a huge amount of in-person exposure time. But really what that meant was that patients were then having that information earlier, were having that information in a way that was really easy for them to kind of engage with comfortably. So in the comfort of their own home on their sofa, they can look through it. They're not kind of signing a consent form under pressure when a clinician's kind of sat next to them and all this kind of stuff. And many patients said that just having that kind of shift in where those conversations were happening and the kind of expectations of what would happen in person actually made it much easier for them to engage with the process and kind of understand their own pace and all this kind of stuff. So what's next? I mean, certainly in terms of the last few weeks, we can see increasingly obviously that this is a long-term shift to remote processes, and I think there's two parts of that. A, there's the necessity of it, and given the scenario that we're in, but also the vast majority of patients and actually clinicians have been supportive and seen the benefits of that shift. So I think certainly as clinicians we kind of thought that maybe patients would like that because of all the things that are often mentioned in terms of not parking and all that kind of stuff. But actually the clinicians have seen the benefit in a way that they were forced into it a little bit, but then quite quickly saw the benefits of it. And there's a talk from kind of Tech Cymru later, which I'm sure will reflect that. But also, any of these paper processes that needed any form of patient interaction, it became impossible. There's that thing where people were moving to remote consultations, and then suddenly were like, oh, I literally cannot do that paper process that required a signature or a survey being filled in by patients, PROMS data and all this kind of stuff, and made it an operational imperative that you had to do it because there was no way that the existing paper processes worked, which kind of interestingly built upon all the other reasons for doing this digital transformation that we already knew in terms of patient experience and efficiency, and in this scenario around consent or legal reasons. But in many ways it's that operational imperative that's actually taken us kind of over the line of people kind of saying, yeah, this would be a nice thing to do, we should think about it, to we actually need this next week, as it were. So those are kind of some quick reflections. I'm going to stay on the call for a decent while, just to kind of take any Q&As, and if anyone's interested in kind of getting in touch, then my details are just there. Thanks very much.
Excellent. Thank you very much, David. Izzy, have you got any questions? Yeah. I
haven't got any here in the chat at the moment, but as you say, you're staying on. So anyone who's posting in the chat, please post to all attendees and panelists, and Dav will be able to have a little look. And if not, we can note down all the questions anyway and pass them on to you afterwards.
Thanks.
So my burning question is that, as you mentioned, a number of the processes that were introduced were forced on clinicians a little, for obvious reasons. But some of them obviously present benefits, productivity and value patient benefits, over and above what the more traditional activity has been. So do you think that these new ways of doing things are going to stick, or do you think people will slide back into older methods?
Yeah, I mean, so I think what we've seen is that the vast majority, and any of these kind of solutions that are are actually good, well, when people are made to use them, they kind of see the benefits and do like it. And so we'd be one of a number of companies where that's obviously we're not seeing a tail off of users once they've been kind of made to start using it. But I think the other bit is that this pandemic, and however many waves that we see, mean that the length of time that we're having to be in these different processes mean that actually you formed lifelong habits. If this was a 4-week pandemic that kind of came and went, it would be very easy for people to fall back into their kind of pre-existing habits. But by the time we come out of wave 2 in March 2021, actually their kind of pre-March 2020 processes will be a long way forgotten. It would be almost as much of a transformation to go back to those as it was to kind of start them in the first place.
I would hope that would be the case, and I've seen examples across the whole clinical community. But I've also seen excellent benefits and of stealth in procurement and adoption of technology, which I do also hope will stick. But I'm less optimistic when it comes to that end of where it's procurement and adoption.
Yeah, absolutely. Really agree.
So you've got a couple of questions now, Izzy.
Yeah.
Yeah. So, what has your experience been like engaging with and selling to the NHS?
Yeah. So, I assume this is a Vicky. So we're kind of in this slightly interesting situation where Innovate funded, and so actually we've had 2 reasonably sized Innovate grants and a Welsh Government grant, which has kind of got us to this point, which has actually meant that we've been able to go into most of these trusts with kind of initial unpaid pilots. And that's been our approach, is to get people using something, and then kind of inform the procurement conversation at kind of 6 months in. So so 3 of our kind of initial deployments are now transitioning into are now going through the procurement process for kind of continued use. So from my perspective, as a clinician running a business, it's a position I feel much more comfortable doing, is to kind of saying, use this thing if you like it, and people start using it, and you use it as much as you want to in the first 6 months, then I don't need to do any selling, really. It's the people internally who don't want to give it up. So that's kind of our approach, and so my aim is to not really sell a product. It's to say, I hope we can solve a problem for you, and start using it. And if it's if enough people want to continue using it, then we go into that procurement conversation forward. So certainly in terms of the kind of COVID scenario, there's definitely been more flexibility in terms of procurement. All of these trusts have been able to kind of bring things through under kind of COVID protocols, and that's meant some differences in terms of procurement rules and that kind of stuff. And so I think, as when you mentioned, I think we're going to kind of move back a little bit in that balance, and it's just about finding where the sensible middle ground is. Certainly in terms of digital health adoption and procurement, we've probably been too conservative historically, and in the last few months we will have seen a few snake oil stuff come through, because there hasn't, people have been allowed to do things without as much process. So I think I hope we land somewhere in the middle, and I think that's where we'll end up. Alan, question in terms of integrating software. Yeah, so we've needed to do a few different things for different places. So some of those big deployments, so Imperial and Chelsea Westminster, we've needed to do some slightly bespoke integrations. They're both Cerner EHRs. So there's an integration for demographics and pushing documents and that kind of stuff. Some of our smaller deployments and some private clients are simply using it with zero integration. So they're kind of entering some basic demographics, and then the end-to-end process works within Concentric. And then we've got a couple coming up now, which are using, pleased to say, kind of interoperable, so kind of FHIR, kind of modern APIs, which are hopefully much more kind of plug and play, which is clearly where we want to get to. Most trusts in reality aren't ready to go with that stuff, but we happen to be working with a couple at the moment who are, so that's great.
Brilliant. Thank you very much for that, and a really interesting presentation. So as Vicky's asked a question, I assume she's on the line and ready to speak. So we did swap a couple of presentations around, though those of you who are more observant will have noticed. So Dav, thank you for stepping up a little bit quicker than expected. And I hope that Vicky from Bond Digital Health is ready to speak on beyond testing, COVID-19 and the value of data.
Absolutely. Can everyone hear me okay? Yeah, okay, great. Well, first of all, thanks very much for having us again. I'm just going to quickly share my screen here. Okay. Okay, so can you see my screen now?
No, I can't see it at the moment.
That might be because I'm on a new machine and haven't set up my Zoom preferences yet, so I might have to duck out and join back in if that's all right. Just.
Or you can send it through to me if that's quicker and I can share.
Yeah, absolutely, that would work as well. Let's do that. Sorry about the delay.
That's fine.
I shall step in and give you a few parish notices while that's going on, because I did want to pick up at the end of this presentation that yesterday some of the companies in attendance will have noted that Welsh Government launched a consultation on a manufacturing forum for Wales, a framework for action. Now, this isn't a sector-specific consultation. This is going across aerospace, automotive, advanced manufacturing, but it is really important that our life science sector is heard loud and proud. There are a number of specific unique factors that many of you will understand in running a life science company, whether that be digital, biotech or medtech, that are different. They're different to running a more traditional manufacturer. And that's not only where the value is in the supply chain. It's about the importance of regulatory compliance. It's about the importance of the international global markets. and interaction between research and development, clinical and industry partners throughout the supply chain. So it's our objective at MediWales to seek to coordinate a response to this consultation. And we will be doing that over the next couple of weeks. We'll be sending out an email to you to give you the questions and the deadlines. Now, this doesn't prevent you in any way from responding in your own right as an individual company. In fact, I would encourage all of the companies who wish to fill out the consultation documentation to do exactly that, and we will forward you the links and the documentation to do that. But those of you who want to just give a quick response, give a quick bit of input, maybe just respond in one particular way, then please do engage with myself and Izzy and Debbie over the next couple of weeks, and we will make sure that your input is compiled into a larger consultation response to Welsh Government. So, Vicky, thank you very much for giving me the time to to provide that little bit of information to our members. And I believe now, are you ready, Izzy?
Yeah, I'm sharing the screen, so that's fine. Just let me know when you want to change slides then.
Okay, we'll do it. Thanks very much. Well, hello everyone. My name is Victoria Agova. I'm head of marketing at Bond Digital Health, and this is our second LifeStories webinar. The first time we talked about our contribution to the ongoing fight against COVID, and more specifically, how we're making rapid diagnostic testing better with data and adding digital track and trace technology. So on the next slide, we tell you why we do all this, which is because we believe that things can be better with data. Our company was founded to fill in the information void initially to help patients with chronic conditions. And now we are helping the entire lateral flow industry go digital and use data to help people. And just to recap, earlier this year, we were awarded over £200,000 in government grants to accelerate the delivery of our digital platform Transform and to adapt it for clients' COVID-19 antigen test. So we work with a Canadian company called Sona Nanotech, who developed an antigen test, and they were the first to commission a white label version of Transform for use with their test. And on the next slide, if we can go there, is slide 4, I think. So antigen tests are what all governments want and need right now. It's what you want when you're at the airport or going back to work. And in the media, we've heard talks about rapid test sensitivity and specificity, but several studies are showing that the key to reopening economies and our societies safely is routine population screening and retesting, where time to result is critical. And in fact, some rapid antigen tests are now on par with PCR accuracy, which might in the future remove the need for a lab completely. So if we go on the next slide, how we're making testing better with data. So what good is all that testing if the data is not being captured and shared with decision makers in real time? And that's the problem we're solving here. For screening testing and surveillance testing to work, we need to understand prevalence in a community to inform workplace and local policies and regional policies. And the results, along with relevant epidemiological data, must be reported in real time. And on the next slide is what we're doing with Transform and how we're making this happen. And Transform is our end-to-end user-friendly data platform. It enables remote capture, recording of test results, and also we have the dashboard, which is where the geomapping of results happens, emerging hotspots can be monitored, and resources allocated in priority areas. which means that decision makers can react quicker and deploy resources where they're most needed. And when lateral flow tests use a reader device, because some of them do, because that's just a more accurate way of reading the result, Transform also connects to that device and sucks all the data and presents it in a user-friendly way. If we go to the next slide, this is the case study with Sona. So we've just launched this. Sona Connect is available on the Google Play Store. So that's the app. And the whole system, so the dashboard, is available for registered users of Sona Connect to log in and view all that data. And there's just a little testimonial from Darren, who's the president and chief scientific officer of Sona. If we go to the next slide. Here we see some of the benefits that the app brings. So there are instructions for use. It guides you through the process of capturing an image of the test strip with the result and then uploading it to the cloud. And as you can see on the last two screen grabs there, it gives you the option to record epidemiological data as well, which is very important to go along with the test results because it adds another layer of value and it helps us really understand what's going on the ground. So if you go to the next slide, this is another screen grab of the dashboard, which shows that you can actually drill down onto an actual test result and see the test location with improved understanding of the disease thanks to all the epidemiological data, which means that we can have enhanced response times and more active allocation of staff, tests, vaccines, and medicines. If we go to the next slide. So, yeah, you may ask, so what, or what's next beyond COVID? And since the topic today is digital health transformation, I want to tell you about all the other health domains where this technology is transformative, and I'm going to close with that. So if you go to the next slide. So we've been advocating about digital technology for years, and it's really a shame that it took a global pandemic for the rest of the world to realize that and the benefits that digitization brings. It's happening now, it's no longer a trend. These are all the areas here that lateral flow diagnostics can be applied in. Some major animal health, food and beverage, and even environmental testing, which is becoming more and more important, food and agriculture, and military diagnostics. So lateral flow diagnostics supercharged with Transform are leading this change. If we go to the next slide. This is another project that we're involved in, which recently got funding from Innovate UK. And we're part of an international consortium with all these companies that you can see here on the right-hand side. So there's Welsh academia, there is Welsh industry partners, there's Sona Nanotech, again, our Canadian partners, and a reader company, Clarity Biosolutions, who are providing the accurate interpretation of the result. And again, the test, the bovine TB test will be based on lateral flow technology, and it will be powered by Transform. If we go to the next slide, I think it just talks a little bit more about the business level benefits. So apart from public health, this is obviously a way for companies now to differentiate their diagnostic products, to enhance their position in their marketplaces and supercharge their business and not just their product offer. And there are potential knock-on effects on other industries once the data starts aggregating. And we're looking at doing some really cool things with the data. So we'll keep you posted on that. And I believe this is it. The next slide is just my contacts and Phil, who's our commercial director's email and telephone number. So if anybody wants to know more, collaborate, please drop us a message. Thank you so much.
Thank you very much, Vicky. And it's really great story to tell, to hear what's happened over the last few months with Bond Digital, in face of quite startling disruption for you as a company. So well, you wouldn't wish COVID-19 to happen, but has it accelerated your R&D and route to market, or has it slowed it? I know that as a company you were already working in these areas of testing and digital applications around testing. So, so has it accelerated the route to market?
Absolutely, it accelerated our commercialization massively. We needed to develop a version of Transform in time before the second wave of the pandemic hit, and the people, the scientists we were working with, they were all getting ready for September, and Sona are currently going through their emergency use authorization, so hopefully that'll be or I don't know if they're currently going through that, but I know they're preparing to submit it to the FDA. So yeah, it definitely accelerated the need for us to develop our solution in time and to help the industry, help more people, really.
Thank you. Izzy, any questions?
Yeah, in the chat. So how close is antigen testing to PCR testing in terms of COVID-19 inaccuracy?
That's probably a bit outside my sort of expertise and knowledge, but I do know that it's quite close. So some antigen tests now are more than 95% sensitive, more than 99% specific. So yeah, pretty close. Not all of them, and of course it depends on what the test is being used for. So there are different scenarios. So for example, there's screening testing, surveillance testing, where in fact frequency of testing is more important than test accuracy. And there have been numerous studies, I think I mentioned, that have shown that. So it really, I think, depends on the end use of the test and the intended use. I personally think all tests have a place in the market, and they all of them will help with epidemiology and preparedness for another pandemic or infectious disease outbreak, as long as they gather the data. Thank you.
Thank you very much. Thank you. And Izzy has seamlessly passed on your contact details into the chat there, so we don't need to dwell on that. So that's great. Thank you, Izzy. Okay, so I'm gonna say thank you to you, Vicky, and hand over to our next speaker. So Simply Do Ideas, company that so Lee Sharma in particular is CEO of Simply Do. So I've not had an awful lot of involvement with Simply Do directly, but given that I've been on secondment to the Life Sciences Hub during the COVID crisis period and helping them to coordinate industry offers and industry support to the NHS in Wales, Simply Do and their platform has become something that is very close to my heart. So I'm trying not to steal Lee's thunder, but I'll let Lee hand over to Lee and let him tell the story. But I can say that I've had an awful lot more to do with Simply Do than maybe either of us realise over the last few months.
That's great. Thank you for that lovely intro. Actually, I'll just share my screen, Gwyn, if that's okay. So I'm guessing you can all see the screen okay? Is that okay? Thumbs up?
Yeah.
Great, cool. So that's a really great intro, actually, Gwyn. I think it's, I'll touch a little bit on that area of work. And I think that's obviously been catalysed by the nature of the pandemic. And I think you said just now that it's never, no one wishes a pandemic, but I think it's certainly seen organisations innovate certainly faster than they would have done pre-COVID. So just a quick intro, just full disclosure as well. I'm not from a clinical background, so please, if we can keep clinical questions to a minimum at the end, that'll be much appreciated. But for those that don't know who we are, so Simply Do Ideas is in essence, we're a digital platform that allows challenge-led business improvement to happen. So just a couple of kind of use cases. So the first one is the one that's probably easier understood, which is the one around employee-driven innovation. So if you think about a kind of the old school suggestion boxes, we're kind of a digital version of that, but with obviously some AI at the end of it to kind of make the data analysis a lot more effective for people to kind of analyze. But the second part of the work, which is what Gwyn sort of alluded to, was around the supplier-driven innovation. So this has been something that we moved into probably about 2 or so years ago, with Rolls-Royce actually as one of our first clients in that space. And most recently been doing work with obviously the Life Sciences Hub, so the procurement of PPE equipment and other kind of COVID-related products from a global marketplace. So it's been a really kind of interesting journey for us, and I think there's been some interesting learnings. But I think that the one project I'm going to talk about today is one around more the employee innovation. It's something that I think is probably something I'm very passionate about, and I've got a lot of friends and family that work for the NHS, and I've kind of seen this this sort of particular challenge sort of almost demonstrate itself in quite dangerous ways, actually. But first of all, we'll give you a quick sort of insight into kind of where the project came from. So in essence, the project was came about through a project called Tech Force 19, which was kind of launched back in March 2020. In essence, there was a call out to digital innovators that could try and support kind of like the battle against COVID, but particularly around supporting elderly, vulnerable, and self-isolating. What they were looking for was new solutions. So potentially, if you had technology that was doing something else but could be applied in a new way, that was quite interesting for them. So our product, for about sort of 4 or 5 years, as I mentioned, it had been used for kind of employee ideas, but very much around kind of business improvement. So very much around, process improvement, new products and services to, reduce costs or perhaps, drive more revenue or income. So this was quite an interesting one because this was very much linked to more around a kind of a mental health and well-being kind of objective, which was obviously very interesting to us as an organisation. So we were quite lucky. We were one of the 18 companies to get selected, and actually some quite free promo, which was great fun. We were put on the NASDAQ Tower, which is a kind of our sort of claim to fame, or certainly of this sort of year, which has been really interesting. But this sort of the problem that we were trying to tackle was, as I said, it was a really interesting one. So I've mentioned about some of the work that we're doing with the Life Sciences Hub and SBRI Centre of Excellence, which was very much around the physical health of NHS employees. So obviously you can see the PPE equipment being worn there in the picture, but obviously it's been very well publicised. And this is obviously absolutely critical to the care of the staff and subsequently the patients as well within the NHS. But something that was and sort of came around actually from my sister-in-law and sort of speaking to her. She's a doctor. She was working in A&E at Princess of Wales Hospital in Bridgend. And talking to her just as kind of the pandemic was kicking off, kind of made me realise around that there's almost this mental health side that is not overlooked, but it's certainly something that is perhaps something that doesn't get the attention that maybe it warrants. So the project that we put forward was around linked to, in essence, trying to create what would be a kind of digital community for those NHS employees to be able to share the everyday challenges they're facing during COVID. So I'll talk about some of the challenges in a second, but this was kind of quite interesting because it was a bit of a kind of a deviation away from our core of doing, process improvement and very sort of commercial ideas. This was very much around how they could support each other with more mental health and well-being challenges. So the objectives, and I won't go through all of them, but the objectives in essence were around engaging 50 employees. We're working with NHS Cwmtaf Morgannwg, who are friends and existing clients of ours anyway, so we know them well, we know the innovation team well. So it was a great place to start. So just on some of the challenges, which I think was a key sort of differentiator from what we would do usually. Now these were very much around the challenges that were being faced by sometimes employees that were in isolation or working from home, but also those that were perhaps in work that were facing, issues around mental health and well-being, potentially those that are at home that are facing lockdown challenges. So some of the challenges that came through, which we decided to go live with, were around, almost sharing hints and tips around staying healthy in lockdown. And some of the ideas were brilliant around, healthy eating, yoga, managing work-life balance when you're kind of, your office is your lounge. It was kind of lots of great suggestions coming through. And I think there were two kind of goals, I guess. The first one was around how you could help the individual to become mentally stronger and engaged with others. And this is obviously, in essence, trying to reduce that sense of isolation and give them that sense of purpose. The second goal, which is around actually focusing on others, was around how could you as an individual deliver value to colleagues. So for example, you would have a colleague challenge or a colleague's comment go live onto the platform, and you'd be able to then go in and sort of search for various challenges, but also give your kind of suggestions and feedback. And it's something quite interesting and powerful in that as well. And ultimately, we're hoping that some of the ideas that would come through would be linked to kind of patient care, but ultimately around helping them be, in a mentally strong place to be able to support patients and ultimately the NHS. Now, it was an accelerated pilot project, which was obviously meant it was actually less than a month. So some of the results I'll sort of share with you now. So in essence, it was actually for around 14 days, which is obviously a tiny period of time. But in reality, it was actually about 10 days of activity. And in that time, we managed to get, an interesting level of users, which was quite good considering such a short time frame. But I think the point that was most interesting was around the challenge views. So in the platform, we have various challenges, and in this case, it was 3 challenges that were posted out to those employees within NHS Cwmtâp Morgannwg. But what we found was there was a huge amount of views, so challenge views, over 1,000 challenge views, which actually, based on the data we've got for other clients, is actually really high. So what we were finding was that people were very interested in going in and not necessarily posting ideas, but they were liking comments and liking ideas and commenting on things more so than creating new ideas. So it kind of had a very much a social media feel about it, but obviously it was in a very much a secure environment rather than being on Facebook or in the open forum. Just some other data that I won't obviously go into too much detail, but again, I'm happy to share this report in full with those that are interested. So what was quite interesting here was that almost 80% of respondents were actually over 45. Now, whether that's just interesting because it was that particular, that sort of audience was receptive because they saw it on the all-staff email or others or from word of mouth. But that was kind of an interesting stat for us with, almost 30% being over 55. I think there was an interesting split between non-clinical and clinical, and it felt that from the data that non-clinical staff, and you can see that 100% would recommend it, non-clinical staff seem to be getting more value than clinical staff. And I think that's something I'll touch on to shortly in the improvements in the looking back section. But I think the bit that was pleasing was around, people felt optimistic about the future by using this, which I think is really positive, and it kind of gives you that sort of, that feeling in your stomach that you're doing some good work. And this was a quote from one of the poll feedback respondents, which again makes you feel that something positive was happening here. I think this feeling of working together is really quite interesting. I think we've seen that on a kind of almost like a global level and macro and micro level, with people wanting to do something. And certainly with this project, we were very much about trying to do something and that old question of how can we help. I think just going on to some of our learning, and then I'm happy to take some questions on it as well. So just going into some of our learning, I think an interesting one was around where it fits within existing provision. So obviously we know there's other digital products that have been approved, including the likes of Headspace and and Sleepio and others. So how would we be differing to the likes of Headspace or potentially any kind of intranet site that gives you information around mental health and well-being? And actually, I think this was quite an interesting one, because if you use an app like Headspace, which is absolutely fantastic, you can meditation, routines, and it's brilliant, great to kind of get you very kind of focused and meditated, if that's even a word. But I think what we were trying to do here was actually about bringing people together to help solve each other's problems and challenges. And that's quite unique, certainly unique from some of the information that we gathered prior to launching the project. But also I think what's interesting is that you would naturally find over time that people would almost be voyeuristic with their initial engagement. So they start off with looking at challenges just out of interest to see what's going on. And what you would typically find, and we find this elsewhere with other clients, is that typically you would find that the people move from being passive to more proactive. So they might view a challenge first of all, then over time they'll start to create challenges. So there is this kind of trackable and traceable kind of movement of employee well-being across that kind of spectrum of activities. So just to sort of find upon our learning is, and I think this is an interesting one, was there was 3 key things that came out of it for us, which we certainly feel we could do better. One was around the position. So, where does it actually sit? So does it sit within well-being? Does it sit within innovation? Within this particular project, we worked with the innovation team because that's who we'd worked with previously. And that was obviously very, very effective. But I think from our point of view, and again, probably looking back at the the clinician and non-clinician kind of feedback, would be we really need more clinician input. We're not, as we mentioned at the start of the session, I'm not a clinician and we don't have that clinical expertise in-house. So I think it is something we need to kind of work with and try and find a bit more clinician input, and particularly from someone from the NHS who can give us that sort of guidance. I think the product's really interesting because I think the peer-to-peer side of it was incredibly powerful. I think, when we initially set challenges, we were sort of, with the first challenge we set, we kind of just almost picked it out of the air and set it because it felt like it was something we should set. The second challenge, and actually a third challenge as well, we actually engaged with employees and asked them what we should set. And those were significantly higher levels of engagement. And I think there's something very powerful about feeling that you're helping someone who could be your peer. And you may not know them, but they certainly work within your organization. There's something very interesting and powerful in that, knowing that you're helping, rather than just almost like a strategic challenge being set by the organization. So unpicking that is quite interesting. And I think proof is an interesting one as well. From our point of view, we use the lovely Warwick Edinburgh mental wellbeing score, and I think it was quite hard to factor that into a poll that would be light enough for people to complete, but equally be robust enough to gather enough data. So again, I think we need some guidance on that as to how we can actually capture evidence as to the impact of what we're doing, if it is something we're going to look to continue doing within this particular environment. So I think, just obviously, thanks for letting me speak today. We're new MediWales members, and it's great to be here as well. And I think it's obviously, hearing from the other speakers is quite inspiring. And I think one thing we've got a bit of an ask actually is that if there is anyone out there that's listening today, or someone who might be able to help us, we're interested in engaging to kind of try and solve some of those problems we've sort of raised as part of our learnings. So again, if there's anyone out there that's got expertise in kind of NHS expertise in working quality, innovation, supply chain procurement, that's very interesting to us right now. We're equally conscious that people don't have a lot of capacity at the moment, so it is going to be done virtually, and it'll be done probably on an ad hoc basis rather than anything too formal. But again, thanks for giving me the opportunity to speak today, and happy to field any questions as they may come in.
That's absolutely brilliant, Lee. Thank you very much for that. And I can just say that from my personal experience, the guys, your team, the guys that Simply Do, in particular, can-do attitude, and they really were quite happy to get under the bonnet of their product offering to make it work for the applications that we required. So we were very grateful for that support that was given. One of the things that interests me, because I've been involved in a couple of projects now where Simply Do has been at the core to the technical as the technology, is where you tend to start considering you guys and your expertise as being a technical expertise. It's a sort of web-based software functionality. But an awful lot of the conversations that we end up having when we're trying to engage with people in innovation projects or sourcing suppliers is around the language, and the subtle differences between whether something is an idea, an innovation, an offer, or a challenge. And I'm just wondering whether your organisation is evolving into one that's becoming far more sensitive around the language requirements of your products.
That's a really great point, actually. And you know, my background was within entrepreneurship, so again, it's a lovely bit of jargon in that as well. And actually, I think sometimes the word innovation can actually be quite confusing. So, you know, if we're working within, say, a corporate space, if we're working with Rolls-Royce, they would always call it innovation. If you're working within, say, an educational environment or public service environment, it would, okay, maybe called innovation, but also it's often called improvement or quality improvement. So I think there is some subtlety in the language that we've had to learn over probably the last 5 years, which allows us to obviously try and communicate better to who we're speaking to. But I mean, I sometimes, you know, the nature of what we do, we're called Simply Do Ideas. We're about, you know, trying to make innovation accessible. But I think the jargon that's thrown around can actually serve to confuse more than help, to be honest with you, Gwyn. So it's kind of, yeah, it's a really interesting point you've made.
Absolutely. I'm sure you'll be able to write a paper on it either now or soon in the future.
Yeah.
So, no, thank you very much for your presentation. So I'm going to, well, I'm going to ask Izzy, are there any questions first before I move on?
But I posted your email in there as well, so from your slide. So if anyone wants to get in touch with you themselves, they can too.
Great, thank you.
That's absolutely great. So thank you very much for that, Lee. And now, as our final speaker, somebody who's probably quite familiar to Lee, and I know that she's familiar with Simply Do. It's my pleasure to introduce Helen Northmore, who's the Programme Manager for the Digital Health Ecosystem Wales, which is based at the Life Sciences Hub. And Helen, your topic is digital transformation. So the floor is yours.
Well, that's a very big topic. So yes, as a lot of people do know me as the Digital Health Ecosystem for Wales. But actually, when it came to March and we were looking at our programme for this year, what happened was that we had a big plan for external engagement. We were going to talk to lots of people about the ecosystem. And then obviously, suddenly, we had no people to go and talk to. So one of the programs that we consider sort of a sister program is technology-enabled care, because they've been looking at the evaluation, understanding and rollout of technology within care and telemedicine, telehealth, and they were looking at video conferencing. And they, and as part of the Welsh Government's response to the coronavirus sort of pandemic, we were looking at systems that could be rolled out at pace that would make a difference. And so it was the start of March that Technology Enabled Care were commissioned to roll out the NHS Wales video consulting service. And that was initially going to be focused around links between GPs and patients. So it was, as you can see, 13th of March that it was announced that it was going to be rolled out to all GPs in Wales. The initial plan was a 12-month programme, and they were asked to deliver this in 12 weeks.
Helen, are you showing your slides? We can't see your slides if you're...
Oh right, okay. Right, okay. Can you see that?
No.
So it should say COVID-19 required a new way of working.
No, we haven't got them up. I think I've got a copy though, if you'd like me to share them.
If that's possible, sorry, I'm having technical problems.
That's fine, I'll share them from my end and you'll be able to see them now. There we go.
Right, yes. So yes, so at the start of March, the Welsh Government asked Technology Enabled Care to roll out to all 405 GP practices in the space of 12 weeks. And the initial plan was 12 months, and even 12 months was seen as an ambitious timetable. But it was felt that enabling GPs to communicate with their patients without that face-to-face contact was a significant tool to ensure healthcare delivery during the period of the COVID pandemic. And we'll get into later some of the results, but it was then in April that it was announced that it was going to be rolled out to cover secondary and community care. And in July, it was announced that it's going to be rolled out to dentistry, optometry and pharmacy. And so one of the things that the ecosystem has done is worked very closely with Technology Enabled Care to help this massive rollout. Next slide, please, Isabel. So this is some of the things that were achieved. And these figures are from early August. So we're now at over 40,000 video consultations have happened since the middle of March. The commissioning was at the start of March. The first video conference was held on the 16th of March, just 2 weeks later, and we're now over 40,000, and it's around 3,000 video consultations a day are happening across Wales, across primary, secondary and community care. And it's live across over 100 specialties, across all 7 health boards, hugely popular with patients. We get loads of interesting case stories. There was somebody who had a dermatology appointment, and instead of having to take an afternoon off work, he was able to conduct that appointment from his place of work, which was on top of a crane. We've also had examples where elderly patients have been saved 100-mile plus round trips for diagnosis of conditions. Hugely positively viewed, and the impact in terms of carbon savings, but also worry, concern, has been absolutely huge. We've trained over 2,500, almost 3,000 people across Wales in how to use the video consulting platform, and there's been a huge amount of how-to guides, videos, and it's been a massive programme. And I think the fact that we've gone from 0 to 3,000 a week in less than 6 months shows that rapid transformation is possible. And I think, particularly driven by the fact that we've been at a time of difficulty and crisis, but actually what we're moving into now is that this service is being seen as business as usual. And particularly around secondary care, we don't expect to see a drop-off in the number of video consultations as lockdown is eased in the future. We expect the number to only go up. And the service is now being transitioned into NWIS and the health boards as service delivery, as business as usual. This is not a new thing anymore. It has fundamentally transformed how healthcare will be delivered for patients and clinicians all across Wales. Next slide, please, Isabel. So I thought the key thing in this conversation was the things that we've learned and how this worked so well. What were the success factors? Because it is a huge journey that we've been through in the last 5 months. And I think it was, initially driven by this, we have to do something to support clinicians and patients through the pandemic period. There was partnership working, and we all talk about partnership working, particularly in the NHS, but actually it was health boards, NWIS, Digital Communities Wales, the ecosystem. We all volunteered people and resources without worrying about what we were going to do in terms of our own programs and KPIs. There was an understanding that this was an overriding objective that we could all contribute to. And also that there was a real collaborative approach across the health boards and the Welsh Government. The process started with the commissioning, the procurement of a mature piece of technology that was rolled out essentially off the shelf with GPs. And even within weeks, it was very clear in the discussions we were having with the health boards and the Welsh Government that normal processes would have been, let's work out exactly what we need for every scenario, and then we will procure that. The process that we chose here was, let's get something in place, let's get it working, let's get it off the shelf, and then we can work out what we need to do with it. So this was starting a journey without knowing the end point. Was quite a different approach to how traditionally public sector have looked at developing and implementing programs. And particularly when it comes to digital health, we talk a lot about the Once for Wales approach. And what was different was, rather than looking at the Once for Wales approach around a product, we took a Once for Wales approach around the service. So this is why we talk about the NHS Wales video consulting service, because not every health board or clinician will use exactly the same product or use it in exactly the same way. It's about giving a consistency around use cases rather than worrying about which product it is. And so that's been quite an adventure for most of us. And hopefully that's changed a culture around how we look at rolling out, particularly technology that moves quite quickly in terms of development iterations and generations. One of the key things for us was that the use cases were developed by clinical teams, because we've been surprised by how some of the specialities and teams across the NHS have wanted to use this. Actually, some of our biggest users have been areas you may have thought might be more difficult, like sexual health themes. And one piece of feedback we've had is actually that patients are preferring to use this where they're in a situation where they're receiving cancer treatment and get a terminal diagnosis, because they prefer being able to have that information at home with their support network around them, as opposed to being in a hospital environment and then having to travel back to where their support network are. Unexpected sort of feedback and use cases that have come through that have shown that if you say this is an option, people will work out how it works for them. And we've seen real development in how video consulting is being used in primary and secondary care. It's never going to be the solution for everyone, every conversation. However, it's understanding where it's better than face-to-face, or where it's actually face-to-face is the right approach. But the clinical teams are driving that, as opposed to that coming from us as this is how you use it. So it's how do you want to use it? Then we establish the use case, then we establish the business rollout model, and that's the process we went through. We also, and I'm obviously going to talk about this because my role has been very much around communications. Again, rather than telling people how to use it, we focused on providing a lot of self-serve information. Particularly people were looking at information, we were tracking results 24/7. We would see that you know, a lot of people looking at information outside of work hours. So although we have training sessions, we also have online webinars that people can attend at any time that suits them. And we have a vast array of toolkits, best practice guides, not just ours, but where we see other pieces of information from other organisations that we think would be useful. We have that on the Tech Cymru website as well. And the other thing that we did that has really enabled us to develop the programme and go further down that journey very quickly and get buy-in is that we had a very strong evaluation work stream right from the start. So from the previous slide, we've done over 140 interviews now, and we've had hundreds, if not thousands of people complete surveys about how they felt about using the technology. And right now we're doing a survey amongst patients and the public, particularly those who haven't used video consulting before, to understand their views around it. This has enabled us to go back to our supplier and say, these are the features that we need to change, these are the way that people are using it, this is what we need next. But it's also enabled people to feel that they have from both clinicians and patients, that they have an opportunity to tell us how they want to use the service and feedback, and so that they feel more bought into it. And it's given us an ability to demonstrate very quickly the impact that this service has had on patients and clinicians. That's a very rapid run through what's been probably one of the quickest 6 months of my life. So Gwen, I don't know if there's any questions.
So I'll just wait for anybody who wants to put one into the chat, and Izzy can keep an eye on that. But in the meantime, I think one of the most remarkable things about the Tech Cymru programme project rollout for me as an observer was the fact that a lot of the benefits and the impact from the project have resulted from it being rolled out at scale. Yeah. It is the fact that you involved so many people, clinical and patient end of the equation, in the rollout, and so many people are benefiting from it. So did that present any specific challenges? Were they managed well? Were there any concerns or issues with just the scale of the rollout?
I think the biggest concerns we had were around rolling out to GPs, because obviously they're independent contractors. And so we were very conscious in the early phases that we couldn't say, this is the service for Wales, you need to use this. We couldn't take that approach. We had to say, this platform is available to you, you can then decide. And particularly GPs were already using other products which were free at the time, like AccuRx. We deliberately took an approach of saying, this is the service that's being supported. If you know, we understand you may want to use other products, but this is available. With the rollout to secondary dentistry and community care, we've been able to say this is the service for Wales, and having that first phase under our belt has made it easier for people to sign up and say this is the service for Wales, and making it easy for them. We have project managers in each health board handling the rollout. So it's also not a big national team. It's quite locally based as well, has meant that they've bought in very quickly. And we actually have more demand than we can satisfy in terms of rollout. We have waiting lists.
Yeah, it does seem like that distributed expertise and resource has meant that the team as a whole has understood the marketplace and the environment that it's been rolled out in, and the subtleties of the differences between the contracts with a GP and a dentist and secondary care. So yeah, I think another one where I think that papers should be written and presentations should be presented at conferences where the learnings can be captured, and much as we at MediWales like to share, and I know the Life Sciences Hub likes to share the successes, I think it really is important that everybody takes the learning and makes it stick. I think that's the important thing. So thank you very much for that, Helen. I know you have your own event to move on to at 3 o'clock, so I very much appreciate you fitting us in, and I appreciate that. So if you have to go, then go. All I'm going to do now is sum up. So we've had, as I've just mentioned, numerous projects that really represented success in adversity, but also represented what is possible. It's probably a horrible term to use now, it's already become a cliche, but the new normal is a positive one in terms of digital technology adoption and implementation. And it really has proven not only what is possible and the speed at which adoption is possible, but also the benefits. And I think hopefully that will come across to a wider community of people in health and social care. The fact that the leap of faith, the adoption in technology, which may have been done initially as a necessity, has resulted in benefits, and a lot of those benefits will be long-term. And I think the Tech Cymru project is a perfect example to finish on in that respect. But we've seen examples across diagnostics, across testing, across communications and innovation project management throughout the last couple of hours. So I'm hopeful that it will stick, but I think it's going to take work from all of us to make sure that the benefits do stick, and that we learn how to adopt innovation better in the future. The digital technology presentation in this series was always going to be the one that had the technical glitches, wasn't it? So I apologize for the challenges we had with the audio and the visual. I hope we managed to get through it together. Sabana, I really felt for you during your presentation. You did have notes on the page. If anybody wants some more information about Sabana's projects or about her work, then her contact details are in the chat, so you can contact Sabana directly. But I think we did get the gist of the presentation, and I think that was really worth doing. So thank you very much for that. Yeah, I mean, the digital platform we've managed over the last, I say we, I mean the MediWales team in its entirety has managed to deliver a program of events over the last 8 weeks where we've presented to over 350 delegates. We've had members presenting success stories and challenges and opportunities from academia, industry, and healthcare, most importantly, and we've had speakers from all over the place. I mean, I was just noticing as I was going through our program today that one of the speakers was in the same building as me, and one of them was speaking from Edinburgh, I assume. So it really, considering what we achieve in terms of getting speakers in front of interested parties, the digital transformation has been accelerated, and it's something that we will be grasping. MediWales will carry on delivering a program digitally, and engagement and consultations, and we're going to need your support you as members, you as presenters, you as partners to do that. And so we'd love to hear your ideas, and we would love to know what you would like to see presented, or how things could change. And maybe we've had smaller events that are more workshop based with more interaction and more Q&A, and we've had the larger events where we've had high quality presentations taking the centre stage. So one of the things we can't do without, because MediWales is a small team and we are an independent organisation, is our supporters and our sponsors. So a huge thank you to AliveCore today, who made today's event possible, and we really do appreciate that. Thank you to our members. Thank you to, I think it's appropriate to say thank you to Greenway Scott, who supported one of our early events in this programme. And we're always grateful to our corporate sponsors, GX, Abel and Imre Roche, and Greenway Scott, and our university partner, Swansea University. So particularly today, AliveCore, we are really grateful for your support, but we really do thank everybody who puts the support into making MediWales possible as an independent organisation and as a network for the network. So thank you. And if I'm doing thank yous, as it's the last event, the people who've really put the effort into this to this programme of events has been Isabel, who's on your screen right now. So take a bow, Izzy, and Debbie Laubach, who has been recruiting speakers and putting a bit of order around the whole concept of LifeStories Live. So thank you very much, Debbie. Thank you, Izzy. Thank you to the rest of the team. And I think we're finishing there. So this is usually where Debbie or Izzy steps in and says, Gwyn, you've forgotten to say this. So here's your chance.
Just mention the awards, MediWales Innovation Awards, 15th year this year, and first time in a digital format. So it'll be new and exciting, but the applications are open now, open to all Welsh organisations or working with the Welsh NHS. So please do apply. There's been, as we've seen, so many fantastic projects that need celebrating and sharing. So we're doing our bit in December, 2nd of December. Registration's open as well to everybody. So please do get involved. It's going to be really exciting. Even though we can't all be in our black tie eating dinner together, we can, do it in a digital format this year. So it'll be really great.
I am definitely going to be in my black tie. So if anybody wants to join me in black tie, then we'll make sure a picture of you becomes part of the awards presentation. So Izzy will be calling me after this event saying, why did you promise that? But we'll definitely make it happen somehow. So yes, please do get involved with the awards. It's always a great showcase. It's not just the night. The night is important, and we will make our digital presentation just as successful, but it's also the fact that those organisations get a spotlight on them for a period of time afterwards through our publications, through our online channels, and through our social media, to just to make sure that the successes in the sector really are celebrated. So thank you again. Thank you, everybody. Thank you, Matt, who was our keynote speaker and gave us a really good presentation. Thank you again to AliveCore, and I think I shall bring things to a close there. Thank you.